Good morning, everyone. It is so great to be with y'all here today. If we haven't met, I'm Brittany, a nurse practitioner with Archer Review, and today we are going to be doing a brand new webinar for me, central nervous system drugs. And this is really great because this is geared towards pharmacology. So whether you're looking to be an advanced practice nurse practitioner, or maybe you're looking at going to, CRNA school or whatever, and you are working in a pharmacology course, this is going to be some really great information for you. Maybe you're already in practice doing something, still really good information just to kind of review together. So we have a case study, we have some questions. So we're just going to go ahead and dive right in. I'm looking forward to our time together. Rachel is in the chat, so if you have any questions, you can feel free to use the chat as always. And I'm also going to let you all go ahead and join my Slido. And I just want to know where you guys are joining from. So you all can put that in the chats, or you all can put it in by scanning this QR code right here and joining at Slido, and we should hopefully have some answers pop up. And of course, as I told y'all every time, I am just still getting comfortable with Slido. So I appreciate you all, just taking time to do Slido and, let me practice a little bit. So that's really great. I think this is like my third time using it. So still getting used to it. But I would love to have you all to join from your Slido right here at the QR code and let me know where you're joining from today. So I'll give you just a minute to do that. And we're going to go ahead and get started here just in a second. I know where I'm at, it's chilly today. It's been a rainy day. Um, and we're all just kind of hunkered down inside. Maybe it's sunny where you're at. We had somebody from Florida last time. All right, while you guys are doing that, I'm going to go ahead and get started. Let's go ahead and talk about the types of anesthesia. So this is just going to be kind of a bird's eye view today, talking a little bit about the types of anesthesia that we can use. And, a lot of times we think about these patients are going to be going for surgery, or maybe they're having something like an epidural, maybe for childbirth or for pain. And sometimes we can also have just topical anesthesia. Think about like your lidocaine. Think about some of the gels that we can use to help to provide pain relief. So when I want you to think about anesthesia, I want you to just think really broadly. And of course, right here, I have them listed for you. I'm not going to read it all the way through, but some prescribing considerations before you prescribe some of these anesthetics. You are going to want to think about airway, of course, breathing and circulation. We always want to protect that patient's brain, especially if they're going to be undergoing something like a general anesthesia. We also need to pay attention and make sure that they don't get like nauseated easy, because if they start vomiting while we're trying to place them under general anesthesia, that can be a big issue for the patients. Of course, regardless of what type of anesthesia we're working with, we always want to monitor for changes, specifically thinking about vital signs. If that patient's going hypotensive, if they're going bradycardic, maybe they're going tachycardic. We want to make sure that they're kind of in that therapeutic vital sign range while they're under anesthesia. Of course, their oxygenation, very important. Of course, after they have gotten the anesthetic, whether they're waking up or they got it maybe, a few hours ago and they are on the surgical floor, or maybe they're in your office, whatever it be, and maybe they're going to be discharged home. We want to think about fall risk, and then also the patient education before and after procedures. So just some things that if we're going to be working to prescribe anesthesia, this is something that we want to be aware of. And if we're taking care of somebody with anesthesia, of course, as a nurse, old surgery nurse here, these are some things that we definitely want to be aware of as we're caring for these patients undergoing any type of procedure and using anesthetics. Of course, how they work is they block pain transmission by depressing the central nervous system. And we have 4 stages of anesthesia. And you can see here, I'm going to point out stage 3 to you guys. This is the surgical anesthesia. And of course, this is really important because we try to kind of keep them in this stage and kind of keep them safe as they go throughout all the stages. So, just something that I want y'all just to kind of pay attention to on this slide again is stage 3. All right, let's take a look here at some of the anesthetic medications. You guys know that we have lots of different routes of medications that we can give. And you all know that oftentimes these patients will receive anesthesia or, pain blocking medications in a variety of forms. Of course, if they're asleep, they might be taking it in the form of IV or gases. And some of the things that we're definitely going to want to pay attention to is if we're really getting into some of these heavier medications. I have listed here for you like things like propofol, ketamine, benzodiazepines. These are, really what I would call like a heavy medication, and we really want to be monitoring our patient very closely if they're getting this, even in very small doses. We want to make sure that the dosage is correct. Also, we're monitoring those ABCs again, and again, if they've gotten those, even if they weren't a fall risk coming into your care after they've gotten these anesthetic on board, we really want to pay close attention and make sure that we're keeping them safe, not only while we're in that state, but then also as they're going into and coming out of that state. Also, we have a little tip for you here. If you are going to be using paralytics, give the sedatives before the paralytic. I don't know about you. I sure would not like to not be able to move and be aware of it. So something just I want to draw your attention to, if you happen to use some of these neuromuscular blockers or these paralytics, whether it be in a critical care setting or the OR or whatever you might be doing. So just some things that you might want to pay attention to here and be aware of as you are working with these patients. Let's go ahead and talk about fentanyl. I have made a slide specifically for fentanyl because this is a very potent, in fact, it's the most potent opioid analgesic. This is about 80 to 100 times more potent than morphine, and we are going to give this in micrograms, not milligrams. So if you ever see an order or write an order for milligrams of fentanyl, double check yourself because it should be doing micrograms. This is at the very top. Like I said, we're also a lot of times seeing this around town, sharing it illegally. And this, has a place, but we have to be very careful. Of course, we don't want this getting out into the community. This can be given in IV, oral, or patch form. This also is for pain control, conscious sedation, and it is short acting, but again, if this is not monitored and titrated correctly, can become deadly very quickly. Fentanyl patches can be used for chronic pain, even for cancer patients. That would be a really good indication there, right? And then also just talking about how we want to rotate the sites. If we're going to be using a patch, we want to, excuse me, I was going to sneeze there. Okay. We want to wear gloves so that the medication, doesn't get on our own skin. And we don't want to, use that patch in conjunction with like heat or cold. So just a few things about if you're writing fentanyl patches or, working with pain management, you want to be sure that you're educating the patient on proper use, proper application, storage, and also disposal of fentanyl. All right, let's talk a little bit about some of these local anesthetics. Like I mentioned at the beginning, there are local anesthetics. First of all, these inhibit pain sensation by blocking the sensory nerve conduction, and these are easily blocked because they're really small, and a lot of times these are kind of not as protected by like myelin sheaths, and so we have the different two classes, the esters and the amides, just kind of changes with how they're metabolized, and then also whether you need it for a short term or a long duration of action, just depending on what's going on. I'm sure most of us have all had some sort of anesthetic, thinking about lidocaine, novocaine at the dentist office, different things that we have maybe had in the past that you might have experienced for a topical or local anesthetic. So just something to kind of be aware of. And then, of course, these patients still can't feel, but they can move. So again, back to that fall risk there. So again, anytime somebody is going to be going under anything that's going to alter their senses, whether it's feeling or, their mind or whatever, we always want to just be keeping an extra close eye on them. All right, let's talk about opioids. So the There are lots of different things. Oftentimes, we'll hear the word opiate, and that is anything that is just extracted from like a poppy flower. Synthetic drugs, they kind of act like opium. Naturally occurring opiates are morphine and codeine. And then you'll have opioids. These are like natural things. They're often used in healthcare. And then if you hear about the word narcotic, it's basically the same thing. It's just often a term that we hear kind of out in the community, kind of what the law enforcement officers will call, these opioids that are kind of on the street or out in the community. And again, right here, just drawing your attention, narcotics are opioids and vice versa. They all just kind of have a little bit different name, but they're all essentially the same thing. All right. So there is your just brief on anything that has to do with pain, anesthesia, just a quick down and dirty for you. Now we're going to go ahead and move into anticonvulsants and stimulants. I pretty much just have the stimulants listed for you right here, and we're really actually going to focus on the anti-epileptics today. We have lots of different names for these, and we're going to try to go through each one, and then I have a little case study for you. So talking about types of seizures, we're going to just have a quick review. Are you guys able to think about some of the different types of seizures and some of the treatment for them? So I want you to think about the different types of seizures and some of the treatments, and then we're going to go through them. How comfortable are you? Y'all can put it in the chats. How comfortable are you with taking care of someone who has seizures? I want you to kind of ask yourself that as we go through this, okay? So, first of all, we have the absence seizure. Often these used to be called petit mal. There are actual no convulsions. Often these are kind of like those staring seizures. Patient will become unresponsive to like voice or touch. Atonic means sudden loss of muscle tone. A clonic is that compulsive muscle contraction with periods of rigidity followed by relaxation. Myoclonic is muscle spasms or twitches, often brief. They only affect one part of the body. Tonic seizures are sustained muscular contractions, and tonic-clonic, also known as grand mal. In the past, these are generalized seizures with full body contractions and convulsions, as well as a loss of consciousness. So I would say this is definitely one of the worst types. And then status epilepticus, which is rendered a medical emergency. This one is a serious condition where basically the patient will have over and over and over tonic-clonic seizures, and it becomes really a true danger to the brain. So just something that you need to think about if you ever see, the patient's family calls in and they are having this many seizures or whatever, they need to go into the emergency room. All right, so let's go ahead and talk a little bit about these medications. So most anti-epileptic medications work by blocking or stabilizing things like sodium, potassium, calcium, chloride channels in the cell membranes. And then also, because of how these drugs work, many will also work with bipolar disorder. So some of these medications that you might see, like for example, Lamictal, has its place in treating epilepsy as well as bipolar disorder. So if your patient has both, that's a good one to choose. So let's talk about phenytoin. So this medication can be given for all types of seizures. It can be given IV. It can treat status epilepticus. And it kind of works by blocking the sustained high frequency repetitive firing of action potentials by prolonging the activation of sodium channels. The therapeutic range is around 10 to 20, and severe toxicity symptoms might be seen around 40. So if your patient is on this medication, it's going to be important to draw like a serum level and kind of check and make sure that they're in that therapeutic range. When we are prescribing this medication, we want to think about side effects. Of course, there's some with their teeth, dizziness, nosebleeds, birth defects. This is a class D for pregnancy. So if your patient has seizures and they're pregnant, this may not be our first go-to. And then also don't want to give this one with antacids because it can kind of lower the levels. And then also GI antihistamines like cimetidine. Think about your famotidine even, because this is going to increase the levels. So if your patient has like gastric reflux disease, this may not be the very best medication to consider with that patient. You might want to choose something else. All right. The other ones we have are carbazepine. This one is one that we also want to check therapeutic levels on, around 8 to 12 micrograms per milliliter. And this one has some adverse effects as well. So just always think about risks versus benefits. This one also can be used for bipolar disorder with how this mechanism of action is. And one of the things that you want to do if you are prescribing this is get a baseline CBC. And that is going to be important for you and just checking that patient's white cells, platelets, and everything before you get started on this. This one here is valproic acid. This one here, it also can be used for bipolar disorder, also has an indication for migraines. Of course, you can see here, you need to check the therapeutic levels of this one. And then also this one, again, several of these can cause birth defects, as you see. So again, if your patient's pregnant, you're probably going to be wanting to manage these patients that have seizures with OBGYN, neurology as well. And again, blood dyscrasias on that. So never hurts to get some baseline basic labs like that complete blood count, the CMP, whatever it be, just so we can kind of keep a pulse on how everything's working with your patient. Also, lamotrigine, that's Lamictal that I mentioned about. This one here can also be used for bipolar disorder. And one thing that I'll point out for this is this one has a black box warning. This one, if your patient develops a red rash, that would be indicative of possibly that severe allergic reaction where they get Stevens-Johnson syndrome. And also that is going to be deemed a medical emergency. And so this is something that you just kind of want to be aware of if you are prescribing this medication. All right, then you have levetiracetam or Keppra. Keep that one in your mind because our case study is going to be about that one. This one can cause drowsiness, weakness, and fatigue. The FDA does have a little warning on there for rare hypersensitivity called drug reaction with eosinophilia and systemic symptoms. If you want to look that up, the acronym is DRESS. And then also this one can lead to things like rashes, lymph node swelling, fever, and kidney injury. Topiramate also has an indication for migraines and OCD. This one is originally a seizure drug. That's kind of how we found out about this one. This one can lead to things like appetite suppression, weight loss, fatigue as well. And then oxycarbazepine. This medication, again, kind of has the same type of side effect profile as the others, can have an indication for ADHD and trigeminal neuralgia. So you can kind of see all of these are working and with conditions in the nervous system. And if your patient has comorbidities, that might help to kind of direct you on where you'd like to start treating them for seizures. All right. Again, just to make mention again, I've got you a slide here for status epilepticus. I cannot say that today. Some of the common causes of this are thinking about alcohol and drugs can obviously affect the levels and bring them out of that therapeutic range. Head traumas, cerebral edema, infection, sudden withdrawal of the seizure medication. So we want to try to taper that off. And then first line is going to be lorazepam or diazepam. Second line is the phenytoin, valproic acid, the Keppra, or the phenobarbital. So just some things to be thinking about if your patient comes into the emergency room, what you would want to do. And again, how do you qualify that? Is seizures lasting more than 5 minutes or repeating over the course of 30 minutes. And this can occur with all types of seizures. So just something that you want to be paying attention to. If you are happening to prescribe benzodiazepines, you're going to want to monitor for respiratory depression and not mix that with opioids. So again, just thinking about the respiratory depression that can cause, thinking about the sedation that these two drug classes can cause together. So you really want to pay attention. So again, can cause brain damage and definitely going to be considered a medical emergency if your patient is experiencing status epilepticus. All right. If you have not already seen this before, I'll just bring this slide up. We're going to just take a quick little break before we get right into our case study. And what we're going to talk about is a patient with epilepsy. But before we get started on that, I want you just to take a couple minutes and scan a couple QR codes. So if you're just joined us in the past few minutes, I'm going to go ahead and bring up the Slido QR code for you guys to scan. And I would like for you, oh, somebody did join from Florida. Okay. Well, hopefully it's sunny there. I would like for you to scan the QR code, and I would like for you to join us for our case study. And while you guys are scanning that, I'm going to just take a quick little break, and I'm going to bring up this other slide and talk to you guys about some of the exciting things that we're doing at Archer Review this winter and spring. So first of all, as always, we have the Q Bank. There's a 7-day free trial for that. So if you're getting ready to take a test, you can, maybe you're studying for something neurology wise, then you can go in there and you can say, I want to take neurology type questions, and you can do that free trial. So I would definitely recommend doing the Q Bank. If you like the Q Bank and you have some more things coming up, maybe you're preparing for your boards exam, I would go ahead and consider subscribing to that. There's over 1,600 different questions with lots and lots of different topics. Pharmacology is actually a huge topic that we have in the Q Bank. So if pharmacology is something that you're kind of working through, this would be a great option for you. The other thing we have is on demand. This has over 16 hours of content broken down by system for you. So maybe you do want to talk a little bit more about, status epilepticus, let's say. You can go there on the on demand and you want to go and look through that and learn a little bit more about that. That on demand is for you, and it's easy for on the go bite-sized videos. And then one of the things that I would just really highlight, and if you scan this QR code, it's going to take you right to that page. There is a pass guarantee. So maybe you are getting ready to sit for your nurse practitioner boards and you're feeling a little nervous about that. This is a big test, it is. It can be nerve-wracking. So we want you to scan and take a look at our SurePass Pro. It has both of these things, and then it also you get to have some live reviews. We have one upcoming next month. You can also purchase that a la carte. And then also mentoring. And one of the great things about having a mentor is we can work with you on whatever you'd like to work with. That is your time, whether it's test anxiety, whether it's going through a topic, whether it's reviewing pharmacology. We're here for it all, and we're happy to look over whatever you need to help you be successful. So if you want to bundle all these things together, the SurePass Pro is going to be your friend here. And regardless of if you buy anything today or you do anything, I'm so excited to have you here at our live webinar. This is a free webinar. We are putting on several of these per month. So we want to connect with you. I want you all to scan this QR code right here and join our community. It's a really great community. We post all sorts of things on social media. That might have even been how you found this free webinar today. So I would just recommend whatever social platforms you're on, you just check us out and join us. And we do a lot of giveaways and a lot of fun stuff on there. Just trying to help you through this journey, because we know that it's not easy, but we want to help set you up for success. And we're excited to walk that road with you. So, all right, let's go ahead and get started in our case study. So, this patient is Bianca Gray. She had a seizure episode that resulted in a fall while at a coffee shop last week. EMS was called and she was checked out in the emergency room and told to follow up with her primary care provider. She has a history of epilepsy with tonic-clonic seizure activity per her EEG report from neurology 3 years ago, and has been stable on the Keppra 500 milligrams BID ever since. She's independent in her ADLs, and she's been back to driving for over 2.5 years now since her last seizure episode. She comes into the office today for workup and is worried. What questions will the nurse practitioner ask? So I want you all to go to that Slido. Let's see if I can pull it back up for y'all. Okay, I want you to go to that Slido, and I want you to think about some of the questions that you might ask Bianca today. So let's see here. Let me pull up that question for y'all. Don't put it on this one. Let's go ahead and ask and put what we would like to ask Bianca today. So go ahead and scan that QR code if you haven't already. And let's see what you all want to ask her. All right, I'll give you just a minute to think about the questions. She's just come into your office today. She's kind of nervous, and see what you think about what you'd like to ask her. Okay, how are you feeling today? Okay, all right. Any recent alcohol use? Uh-huh. What else would you guys like to? Okay, I got two more typing. All right. Anything else y'all want to ask? Right. Okay, some good questions to get started with. So I'm going to go ahead and bring us back here. All right, so let me give y'all a little bit more information from the initial questions that I thought of. First of all, I would want to know kind of what y'all asked, how she's feeling, alcohol use, caffeine use, and her alcohol use has been moderate. She has had heavy caffeine use. She has heavy exercise. She's a swimmer. She denies insomnia. She reports one seizure last week with an occasional migraine, no dizziness, nausea or vomiting, or numbness noted. She's been having some increased stress and anxiety because she's been caring for her older mother, but she states that she has not missed any doses of Keppra. Okay, so hopefully that gives you all just a little bit more ideas. Let's see. Okay, any changes in how you're taking the med? Very good. That's right. So great job. All right, so keep that slide up because, or keep that QR code up because I'm going to let y'all ask some more questions, and y'all can put it in the chats too if you don't want to join the Slido. That's okay. All right, let's go ahead and look at our next slide. Okay. So I want to know what you guys would like to do for your assessment and plan. So what is your initial workup going to be? You guys have some background information on Bianca. And I'm going to go ahead and pull the Slido back up. And let's see here what y'all would like to put. And let me go ahead and change that Slido over for y'all. Okay. All right. What systems would you assess? What diagnostics would you like to go ahead and do today? Okay. So, what you thinking about you'd like to do? Go ahead and scan that QR code if you haven't done so already. I'll put this up here for you. What assessment and plan would you like to start with for Bianca? So go ahead, put your answer in. It'll come up as a little bubble, just like, and this is totally anonymous on here. So, we don't know who's putting what. So go ahead and just write in what you would like to do for this patient today. All right, CBC and Keppra levels, EEG, very good, very good. What else? What else are you thinking about that you would like to do for Bianca today? Would you like to get started on? Okay, all right, CT scan, okay, all right. Yep, physical assessment, absolutely. So what are you thinking about physically assessing today? Are you going to do a full head to toe, or are you going to do more of a focused assessment? What physical assessment findings or systems, should I say, would be at the top of your priority list? Do y'all have any certain systems that you would like to assess in particular? Yep. Focused head assessment. Absolutely. Yep. Cranial nerves. Absolutely. That's a great part of a neuro exam. Okay. I'll let y'all sit with that for just another minute. So think about anything else. If you've already added, you can continue adding. It's okay. If you think of something, because this list is really great. Y'all are doing a great job. Okay. All right. Okay. Great. So all great answers. Absolutely. All right, let's go ahead and proceed here. So this is some of your findings, okay? The vital signs were as follows: 112 over 65 blood pressure, heart rate 82, respiration is 15, temp is 98.8. So all that looks pretty good to me. Neurological exam is no deficits. Perla, so that means those pupils are equal, round, reactive to light. She has symmetry on both sides of her face and body, and her reflexes are within normal limits. The lungs are clear, all fields, and not respirations, regular rate and rhythm, and no murmurs noted. And this patient is well developed with no distress and normal affect. So we get our diagnostic labs back. So here's the answer to that Keppra serum level. Which one would you like to look at? So it's a 6. So who can tell me if that's normal or not? Your comprehensive metabolic panel is unremarkable. Your EEG is within normal limits, and your MRI of the brain is within normal limits. So what you thinking here? What you thinking that might be the issue? About what could be the issue? All right. So let me give you a little bit more of the story on Bianca, and then we'll move on. All right, so let's go back to this slide. So we're going to assess the therapeutic range of the Keppra, and if you know that lab value, it is low, okay? The electrolyte panel basically ruled out metabolic abnormalities. The EEG, we wanted to repeat that study. That was absolutely right to assess current seizure activity. And then we might consider the imaging is fine, and it turned out that there was no structural abnormalities found. All right, so I'm going to go ahead and bring up the Slido again. And I've got some things that you might want to educate Bianca on via the phone. So, her labs have come back, her MRI reports come back. Maybe she's at a follow-up. Maybe you're going to have staff to reach out, whatever you would like to do. And think about what you would like to talk to Bianca about today. So think about stress management, think about, what kind of follow-ups. Think about what advice you want to give to her today. So I'm going to go ahead and bring up the Slido again. If you're just now joining us, you can still scan the QR code and get in on this. I'll give you just a minute to go ahead and respond. So what type of stress management strategies would you consider for Bianca? She said that she was kind of stressed with her mom. She's been taking care of her, right? What about her caffeine and alcohol consumption? What advice would you recommend for that? Or if you recall from earlier, she's drinking a lot of caffeine and some moderate amounts of alcohol. Also, what about seizure safety? She hasn't had one in almost 3 years, or in a little over 3 years. So, thinking about reiterating those safety concerns that we might have, because she's kind of been back to her normal status quo for the last 2.5 years. She might have forgotten some of those things. So, what types of things would you want to educate her about for her triggers and avoidance of seizures? And then also safety precautions. It states that she drives alone, and it states that she's a swimmer. What about follow-up care? What would you consider for this patient would be an appropriate time to follow up? What about her medication? Are you going to change that dosing? So you all think about what you would like to do. When would you follow up? What are you going to educate her on? She's on 500 milligrams BID of Keppra. So what are we going to change our dose to? And if you recall, her therapeutic range was a 6, or her serum level was a 6, which is low. Okay. All right. And again, remember, there's no there are some correct answers or answers that are better than others, but right, this is not super black and white. This is you guys kind of working together on this case study. So y'all are doing a great job of putting in all the things that you would want to talk to her about. Absolutely. Okay. I love it. You guys are doing great. All right. What about driving specifically? We put drive safe. Is there anything in particular that we want to say to her about driving? And what about swimming? She wants to know if she can get back to the pool. She does pool exercise almost every day. Okay. Yep. Absolutely. Decrease alcohol and caffeine use. That's right. Absolutely. All right, so some of the things that I kind of wrote down is stress management strategies, of course, thinking about mindfulness, thinking about counseling or therapy if she needs that. Taking a day to your self was a great idea that you had on there, right? She needs a little bit of respite care, caring for her mom. Maybe she has somebody that can help her with her. Also, advising decrease of caffeine and alcohol, especially during stressful periods, because that's just going to increase brain activity or make her more sedated with the alcohol. Also, going to educate about seizure triggers and avoidance. Obviously, alcohol and the stress level can increase her threshold for seizures. Also discussing safety precautions, so things like avoiding swimming alone right now, and also driving restrictions as per the local law. So she may not be able to drive for 6 more months. She may have to have somebody, go with her to make sure she's been deemed safe. Probably going to schedule a follow-up within a week or a month or two and check and make sure that she has had a therapeutic adjustment to the Keppra levels and review her test results again with her. And then, of course, providing our contact information for immediate concerns, especially if she's going to have another seizure. And she does have a neurologist that did the EEG 3 years ago, if you remember. So we might want to have her check in over there, make sure that they can help to sign off on her, driving again, and that they're good with her dose adjustment of her medication, and see if they want to add anything else to it. So very good. You guys did great on that. Very good. All right, so let's go ahead and look at this. Here's your resolution. Bianca returns to the clinic in 3 weeks for a serum redraw, and it's 24 micrograms per milliliters, and that's within normal limits. She reports no side effects on increased dose. She will avoid driving and swimming alone for 6 months. She'll touch base to follow up with her previous neurologist within that time frame. So you guys got all those things. So great job. I hope y'all like that case study because it kind of helps to try to pull everything together for you. All right, I want to give y'all just a little bit more content, and then we have a few questions for y'all at the end. So hang with me. Y'all are doing great. All right, I'm going to talk a little bit about headaches now. If you've seen some of my previous neuro stuff, we've talked about headaches before together. Just as a reminder, we have different classes of headaches. Primary headaches, so I want you to think about things like migraines, cluster, and tension headaches. These usually have no underlying cause. Secondary headaches do have an underlying cause, so it can be anything from a simple sinus infection all the way to something like cancer, or meningitis. So again, it can be very benign and easy, or it can be very concerning and really bad. Acute headaches are going to be those short-lived things that happen for just a few hours to maybe a couple of days. And then a chronic headache is considered 15 or more headaches days a month for the last 3 months, and that's according to the International Headache Society. And for this lecture, we're going to basically be talking mainly about migraines is what I really wanted to pull out for you guys. So first of all, migraines, we don't really have a great answer as to why these migraines happen, but we do know that there is a genetic component, and we know that women are going to be having a lot more migraines usually than men, thanks to those hormones like estrogen. We also know that there are several triggers that can be associated with migraines. So thinking about everything from stress, lack of sleep, changes in the weather, alcohol, different foods like aspartame, tyramine. So think about chocolate, cheese, and wine. Even things like smells, like perfumes or cigarette smoke. And pretty much those are going to be those pounding, unilateral, one-sided headaches. And these can be often accompanied by things like nausea, vomiting, sensitivity to light and sound. And patients also might have something like an aura that kind of precedes that migraine. So things like a flashing light, tingling of extremities, strange smells. It's going to be different for everybody, but patients will often say that they know that that's how a migraine is coming on. And you guys can put in the chats, there's going to be a question about this here later coming up, that there's a class of medication that is specifically contraindicated in childbearing women, or should I say women of childbearing age, and that is those estrogen-containing birth controls if they have migraine with aura. So diagnosis is usually clinical. This is going to be based upon their patient history. Sometimes we will get some imaging, especially if they are older or if they're pregnant, over the age of 50, or, experiencing things like worst headache of my life. This is like a new onset. Those red flags of headaches that you might have seen or read about in the past. Of course, we have abortive medication and prophylactic medications, and we're going to go ahead and talk a little bit more about that here on this next slide. So some of those first line agents, of course, we can use NSAIDs if the patient can tolerate it due to things like their kidney function. They're not on like things like anticoagulation therapy. So that's going to be like your Advil, your Aleve, your Motrin. And then some first line prescriptive things are going to be things like the triptan class. Okay. So basically things like these are the abortive meds. So when the patient has a migraine, they take this medication. Of course, we don't want them taking it every single day. So this is just going to be more as an as needed medication. And these do have some side effects, things like flushing, tingling, dizziness, GI upset, nausea, and vomiting. And then these are contraindicated for patients with a history of MI, peripheral vascular disease, uncontrolled hypertension, or stroke. And because these cause vasoconstriction, you are going to want to make sure that they're not, super hypertensive. So you want to monitor their blood pressure, and also their mental status. And sometimes they can even manifest things like serotonin syndrome type symptoms. So this is something that you want to pay attention to because these will raise the blood pressure even more. And then often just one of the side effects that's kind of benign is skin flushing after administration. So again, this is in the abortive category. These patients are going to take this at the onset of the headache. Some of these medications even have an indication where they can take an additional dose an hour or two after if it's not helpful for them, but no more than 2 in 24 hours. All right, so again, just listing a few of the abortive agents for you. Remember, these stop migraines in their track. And again, the first line is going to be prevention of these headaches, avoiding their triggers. And then first line is going to be NSAIDs. And then second would be the triptans. And again, if these are, not working or they're contraindicated, then there are some other meds we can consider. Topiramate, that was listed on y'all's seizure section back there, wasn't it? And this helps to abort migraines by calming down the electrical activity in the brain. One of the side effects of this is weight loss, but it should not be prescribed for it. Also, valproic acid is also another anti-epileptic drug that was on that list, and it helps to calm the brain as well. And again, then you also have those CRGP inhibitors. These are really a kind of newer class. These are a unique class in that some of these meds like Ubrelvy and Nurtec are listed under, and they work to kind of calm that inflammation in the brain, reduce that CRGP, and these actually can be preventative as well. So in this class, so like Qulipta falls in this class, and the injectable Emgality falls in this class. So this kind of has like a multi-use, if you will, but these that I've listed here for you are usually used as a board of the Ubrelvy and the Nurtec. So kind of just a unique class versatility there. Okay. So let's go ahead and talk about beta blockers. Again, not first line, but an option here. If your patient has high blood pressure or arrhythmias and anxiety, this might be helpful. Calcium channel blockers like verapamil. Again, if this patient has some CV indications, this might be a good option for them. And then amitriptyline, again, good for migraine prophylaxis. It is considered a tricyclic antidepressant. So think back to TCAs and what they do and how they work. And then, of course, if your patient's already on an antidepressant, like maybe an SSRI, it can increase the risk of developing serotonin syndrome, which again is an emergency. So may consider avoiding that class if they're already on something for depression. All right, let's go ahead and those are your first line migraine medications that you can think about for your patients. And let's go ahead and talk a little bit more about these migraine medications. And go ahead and pull up your Slido if you have it. And I'm going to let you guys go ahead and fill in on here. Let me just change this over for y'all. Let's see here. Let me see. All right, let's go ahead and take a look at this question right here. Okay, so nurse practitioner is counseling a 32-year-old female patient with a history of migraine with aura on hormonal birth control options. Which medication is going to be the best recommendation? So you guys go ahead, if you haven't already, pull up your Slido and go ahead and answer this question. So what you thinking? Norethindrone, um, the NuvaRing, the Low Seasonique, or Bayaz. So take a look and pay attention. And why would we want to maybe change this up? All right. Okay, very good. Great job, guys. That's right. It's A. It's the one that doesn't contain the estrogen, isn't it? Great job. All right, let's go ahead and take a look at this second question for you guys. All right, well, let's see here. My share is wanting to go down. All right. Okay, let's look at this second question together. So, which medication can be given as an abortive therapy for an adult experience a grand mal seizure? So, we talked about that a little earlier. What are you all thinking about out of this? Okay, Keppra, it was listed. That's right, absolutely. Okay, very good. All right. Okay, anything else? All right, let's go ahead and take a look at our next question. All right, this next question here is coming to you. So the nurse practitioner is considered prescribing an opioid for pain management. Before prescribing an opioid, the NP checks to see if the patient is on any blank, name that drug class, and if so, might decide to change the plan of care. So go ahead and I'm going to let y'all vote on this next one for you. Let me just get it pulled up. I don't know why. So just go ahead and put it in the chat. I don't know why this is not working. Go ahead and just put it in the chats for me. What one do you think? A, B, C, or D? And I'm going to go ahead and pull up the chats. Rachel's still there if you all have any specific questions, by the way. All right, let's pull up the chats. What y'all thinking on this one? All right, let's see. For some reason, this Slido is not wanting to do. So I'm just going to take that off. All right. Nurse practitioners consider prescribing an opioid for pain management. Before prescribing an opioid, the nurse practitioner checks to see if the patient is on any blank and may decide to change the plan of care. So y'all just go ahead and put that in the chats. So what you thinking? So proton pump inhibitors, ACE inhibitors, benzodiazepine, or SSRIs. I'm going to check the Zoom chats. All right, so what do you all think should not be given with opioids? If you picked benzodiazepines, you would be correct. We do not give benzodiazepines and opioids together except for in some sort of rare circumstance, but we try to avoid that altogether. All right. So that's the end of our lecture time today. I'll take just a moment if you have joined us prior to beginning our case study and just remind you all of all the exciting things that Archer is offering this semester to help aid you in your studies. We'll be happy to meet with you one-on-one for a mentoring session. We'll be happy to help you, discover which products would be good for you. And even if you end up just continuing to come to these live webinars, we're happy to have you every time. There's going to be more coming up this week, so be sure to scan this QR code and join our community. It's a really great and supportive community of nurse practitioners and advanced practice RNs, and we're just growing by the day. So if there's anything that we can help you with, you can email us for questions at nursepractitioner@archerreview.com. And if y'all have any certain questions today or anything that we can help you with, Rachel and I'll stay on for just a minute and address your concerns. So if you are finished, you are good to go. And otherwise, I'll hang around here for just a minute and see if you need to check in. You have any questions, anything that we can talk about together and get cleared up for you before we go. All right, now I'll open up the chat box. You need to go, that's fine. All the content has been covered. All right. Well, I'm going to go ahead and not keep y'all on your Monday today. I hope y'all have a great week. I'll see y'all again soon. Check our social media down here and see if there's any other webinars you want to sign up. I'll be back in a couple of weeks. But in the meantime, there's lots of that stuff going on. So be sure you check us out on some of our other webinars. Look at our website, see if there's anything we can do to help you.